Hello, everybody. It's Susan Thornton with the Cutaneous Lymphoma Foundation, and welcome to this month's edition of our Facebook Live. And tonight we have with us Dr. Elizabeth McBurney, and she's joining us from the lovely state of Louisiana, and the Sonova Dermatology and Tulane School of Medicine, close to New Orleans, but a little bit outside in Metairie, right, Dr. McBurney?
It is. It's about 2 hours from New Orleans.
Yeah, so it's really lovely to have you with us. And tonight we're going to have a little different twist on the theme where it's more of an open question and answer opportunity. So for everybody who is joining us tonight, it's an opportunity for you to get your questions answered. We're not going to have a formal presentation of any kind. And we're going to just get started with some questions. So if you will write your questions into the chat, and then we'll post those on the screen and I'll read them, and Dr. McBurney will do her very best to answer them to the best of her capacity. And I'll just say that, you know, we had a really wonderful patient education program with Dr. McBurney and everyone from the New Orleans area back in March. And the Q&A panel that we had was so wonderful that we wanted to try to recreate that a little bit by having Dr. McBurney with us tonight. So we'll go ahead and get started. I don't know, Dr. McBurney, is there anything that you'd like to share before we dive into the questions?
No, Susan, I don't have anything. I just want to thank y'all for inviting me to be available to our patients with cutaneous T-cell lymphoma.
Well, it's really wonderful to have you. And I'll also say that Dr. McBurney has been treating patients for quite a long time. So we're thrilled to have her knowledge and expertise with us. So I'll go ahead and kick off the questions. We got a couple of folks that sent their questions in prior to our program tonight. So this one's for Jim. And he wrote in and he said he couldn't be here tonight, but he did have a question. And he wants to know exactly what happens to the cell when mycosis fungoides has large cell transformation, and how does this affect the prognosis? So I think that's a really common question. You know, we hear a lot about there's mycosis fungoides, and then sometimes people have this large cell transformation or some sort of transformation of their mycosis fungoides. So maybe you can share a little bit about what that might mean and how that might impact someone.
Well, if a patient has had the typical forms of mycosis fungoides, that is patch and plaques on their skin with the indolent course over a long period of time, and usually what you see is that then clinically they will develop a tumor nodule or a severe worsening of their disease. And when we biopsy it, they will have what we call blast transformation. And what this means is that those small lymphocytes, the cancer lymphocytes, now have gotten very large. The nuclei have become very enlarged, and generally it has a poorer prognosis. Usually it transforms into a more rapid clinical course. Now that is very general. There can be some blast formation locally in a lesion, and we will treat that lesion, say, with radiation, and it will resolve and go away, and then we don't see any more blast transformation. So there's a great variation, and when you'll hear the term blast transformation, usually it is not a good sign. It's not something we like to see. It means the cancer is no longer being controlled or responsive to our immune system suppression, and the cancer has become, think of it as being independent and going on its own. And so it's not usually considered a good sign.
Right, right. But interestingly, that then it's really important to biopsy those lesions because, as you said, sometimes it may just be in one area that seems to be changing, I guess, right? So sometimes it is localized, but you really need to be able to biopsy and keep track of what's really going on in that individual patient.
Exactly, Susan. I think that's so important. Anytime when you have a patient with mycosis fungoides that has a disease that has had a very indolent course, and suddenly there is a clinical change in the appearance of the lesions, particularly if a nodule grows or a tumor nodule appears, we always take a biopsy at that time. And I encourage my residents and the physicians that I work with to always biopsy these lesions and to see what's happening histologically at the cellular level.
Yeah. So once again, biopsies are really important, especially in this disease. And one of the things I always share with folks is, we as patients are in the best position to monitor and to watch our disease. So if we really need to keep track of how it is behaving in our bodies, so we can understand when it may change and when it looks different. So, I think today it's great to have, we all have iPhones and smartphones, and we can take pictures, and I think that's really a helpful way of being able to monitor how our disease is doing, even how it's doing with treatments.
That's a very good point. No one knows your skin better than you do. And I encourage my patients to be familiar with their skin. And if they can't do that, to ask their partner or their spouse or their significant other person in the household to help them watch their skin. And if they notice any change, to go ahead and take a photograph and mail it to your physician. And I receive pictures every day almost from patients asking me, is this bad? Is this okay? Sometimes we can tell, sometimes we can't. I have to say, you need to come in, I need to look at you. And other times I can be reassuring and say, no, I'm not concerned about that. And that's one of the beauties of this new technology is we can almost go into the home with the patient with the iPhones that we have today.
Yeah, and that's a good thing, right? Especially in an area that, for example, like you are in, where a lot of people are far away, so, having to come in and travel a couple of hours, sometimes you can alleviate some of that. So we're grateful for technology. Sometimes it's good, sometimes it's a little more challenging, but all good. Okay, so I'm going to read our next question here. So we have, and I think this is from Megan, who put this in a little bit before our webcast. Her son is 13, and they're trying to determine exactly what his diagnosis is between lymphomatoid papulosis and primary cutaneous anaplastic large cell lymphoma. And she's asking, he's played competitive soccer for 3 years on artificial turf fields, and wanted to know if there's any link between artificial turf and various forms of lymphoma. Is it reasonable to think that this exposure may have some sort of impact on the condition?
This is an issue that, unfortunately, we don't have good studies, and I don't know. First of all, remember what the artificial turf is made from. It's made from pulverized tires, all kinds of tires. So we've got a conglomeration of various chemicals that are in the material in the artificial turf. There have been some anecdotal reports, that is, case reports, and there have been some news stories that have appeared in some of the national newspapers suggesting that there may be a link between lymphomas, Hodgkin's or non-Hodgkin's lymphoma, and exposure to artificial turf. However, when you try to drill a little further into this, there are no studies that substantiate this at this time. And my current feeling about that is that we've got to keep an open mind, and I don't feel that I need to tell my patients they have to quit playing soccer or quit playing on the artificial turf. We need to stay aware of the literature. The studies need to be done, but at this time, we just don't have the data that supports us saying there's a direct link there.
Great. Yeah. Yeah. It's all about, data, and especially in a rare disease like cutaneous lymphoma, even harder to pull that kind of data together to make any kind of connection. So, but we're all staying in the loop, and if we find any information that would support any of those things, we'll certainly be letting folks know. She has a second question. Apparently her mom has a history of hairy cell leukemia, and she's wondering if there's a link between that and LYP, and maybe, is there any genetic kind of connection?
Right. I'm asked that very often by my patients. We will always ask if there is a history of leukemia or lymphoma in the family. It does seem that in some families, there seems to be a predisposition to leukemias or lymphomas. We have not, however, been able to find one genetic abnormality or one genetic basis for this. It's just unfortunate that there has been some grouping of these in some families. I do not think that the hairy cell leukemia is directly related to the lymphomatoid papulosis or the primary cutaneous anaplastic large cell lymphoma. But the tendency within that family to have leukemias or lymphoma is possible. And I do occasionally see this, but we don't have in mycosis fungoides or cutaneous T-cell lymphoma, we've never found one genetic abnormality that is unique to all cases. There have been various genetic abnormalities found, but not one, as there are in some other diseases that we have, such as cystic fibrosis and things like that. We don't have that in this disease.
Right. Yeah. And I was just at the Society for Investigative Dermatology last week, where some of the presentations were talking about, that very fact that we don't have, and there probably will never be, just one particular even pathway or one gene or one thing that we'll be able to point to that is causative of cutaneous lymphomas, that it will most likely be a variety of things. And that's why the research is so important, to try to figure out at that deep cellular biology level, what's really happening. There's pathways and there's markers and there's all different kinds of things that go on. And it's almost like the perfect storm that creates the environment where these cells can proliferate and take off. And trying to figure out which ones are the most important is really the key, so that we can figure out how to best treat. But it's we've got more work to do.
A lot of work. That's right.
Okay, so here's our next question. What percentage of patients have their CTCL transform, and is it related to the age with which the patient is diagnosed? So is it an age, maybe how long people have had it, or does that not matter? And then I guess percentage-wise, I guess we could take mycosis fungoides as the most predominant variant.
Right. Mycosis fungoides, as you just pointed out, Susan, is the most common variant of cutaneous T-cell lymphomas. There are many others, but that one is the most common. Over 50% of them are mycosis fungoides. Now, fortunately, most of those cases are going to remain indolent, and do not have the so-called blast transformation that I was speaking of earlier. It is very, very low. It generally occurs later in the disease, and it tends to occur, of course, in older patients as the competency decreases with age. And so that we can see that both as the patient gets older, and also we can see it depending on what kind of treatment they've had and what kind of immunosuppression they've had. And as a result of that, can allow for the blast transformation to take place. However, I would really want to be very reassuring to people who are listening tonight that most patients with mycosis fungoides in the early stages are not going to eventuate into blast transformation.
Right, right. And, and I'll just share a little bit of my background and history. So I'm coming up on almost 30 years of living with mycosis fungoides, and I was in that very small percentage of people whose disease progressed, but it was over the course of a 6-year window, and I was able to get treatments even back then in 1998, and here I am. So, there's always options, and there's always things that we can do. And I think, sometimes I just, I'm living proof that you can be around a very long time with this disease. Okay. Can't be there for the presentation, but a question. What exactly happens to the cell when, we answered this one. Sorry, Mike, we answered this one. Hopefully we'll have another question here in a minute. Please, again, if you have questions, please send them into the chat box and we'll answer them. Here we go. I knew it wouldn't take people very long to ask a question. I've had repeated radiation treatments around my eye patch. Let's see. I've had repeated radiation treatments around my eye, and my eye patch is back with bottom lid, ectropic eyelid. Is it common? Not sure. I'm guessing they've had radiation around their eye and now they have ectropic eyelid, maybe because of the radiation.
Well, certainly that could be possible, and also because of the disease. And this is one of the problems around eyelids. Fortunately, most of the patients with eyelid nodules or plaques can be treated with radiation, and very successfully, in that very small doses of radiation are quite successful in treating them, because these lymphocytes that are the cancer cells in mycosis fungoides are extremely radiosensitive. So we're not looking at having to give very high dosages of radiation, but we can give fairly low doses. What we do have to be careful of when we're giving radiation around the eyes is that the leaded eye shields be inserted over the globe of the eye to prevent irradiation of our iris and our retina. And also, eventually, you're going to get some retraction and some scarring and some what actually an ectropion is the pulling down of the eyelid. And that can happen both from the disease and from the radiation, such as we will see ectropion in people who have Sezary syndrome and who have never had any radiation. And so it's kind of hard to say which came first. I'm not seeing the patient who's asking the question, but it unfortunately is one of the problems. And we frequently have to use liquid tears or sustain, which you can buy over the counter, and you have to keep the eye moist as much. Occasionally, we have ophthalmology get involved, and they can surgically make a difference too.
It's a very good point. Very good point. Yeah, and those areas are a bit challenging sometimes to treat, just location and all of those things. Okay, I was diagnosed with MF this past month, 11 years ago. So they've had it for 11 years. Went through 3 rounds of chemotherapy to combat testicular cancer. The 3 drugs were bleomycin, ectropic, and cisplatin. Is anyone aware of a connection to CTCL MF and these type of chemo drugs? So it sounds like perhaps he had the chemo before maybe he was diagnosed with MF. So if there's any connection between those drugs and that treatment.
I am not aware of any studies that show direct connection of cutaneous T-cell lymphoma to those 3 drugs that he was used to treat the testicular cancer. However, what we do know is that people as a general rule, people with one cancer, in this case, we're talking about cutaneous T-cell lymphoma, can need to be monitored for secondary cancers. And we certainly do see this, and there's good data to show this. We've found it in our patients here in Louisiana. There have been good studies that have been published that have shown this. The most common ones we see are the non-Hodgkin's lymphoma, but we've also seen melanomas, we've seen bladder cancers or urinary urogenital cancers. And that is one of the reasons I am so adamant about our patients, all of our patients, being sure that they have their annual checkups, that they keep up to date on all their health procedures, such as the breast mammogram, such as the colonoscopies, such as the prostate exams, that they get checked regularly for all of these, because we know that they're at an increased risk of developing another cancer.
Mm-hmm. Yeah, so general rule of thumb, do your annual screenings, and just like everybody else, but those of us that have cutaneous lymphoma have a little bit of a higher risk. So good to keep on top of all of that and current.
Absolutely, Susan. And I tell patients, if they develop a new symptom, they coughing blood, or they're having blood in their stools, or any new symptom that does not resolve fairly quickly, they need to not ignore it. They need to go and get that checked out, because that can be an early warning sign that there is something abnormal going on.
Right, right. And we all like to ignore things for a while. I know I'm good at that. So don't follow my advice. Okay, so my husband was recently diagnosed, and we are still learning about cutaneous T-cell lymphoma, mycosis fungoides. His doctor recommended Valchlor to treat his lesions. Are you aware of any effect on fertility or conception caused by Valchlor? It's a very good question.
I'm glad you asked that. For those, the quick answer to that is that you need to know that the Valchlor, once it is applied to the skin within a very short period of time, it is inactive. It's inactive. And it's one of the topical drugs that we can put on the skin that there has been no data to show that it is absorbed transepidermally, that is, through the skin into the blood, which makes it, puts it in a very safe, in a safer category than a lot of our other drugs that we use. I personally would prefer, when people are trying to conceive, I personally prefer them not to be using the Valchlor, and that's going to be the recommendation you're going to find on the package insert. But I feel that that's probably one of the safer drugs that we have that you could use and feel fairly comfortable about conceiving while on the Valchlor.
Mm-hmm. Yes,
I
it's good to know, because That's good. That's good to know. And that was a great question, because I think those are things sometimes we think, oh, well, it's just a topical on the skin, and don't think about whether or not that particular drug is absorbed in any way that could have an impact on fertility and things. So it's always good to ask those questions and to pay attention, and to think about that. And
Yeah.
you know, maybe there are some other alternatives that they may want to consider, like light therapy or something, if that makes sense.
Absolutely. And I'd like to point out too, to the person who just asked that question, that if you go on the website of the Cutaneous Lymphoma Foundation, they have a wonderful list of all the drugs that are used to treat mycosis fungoides and the effect on fertility and the need for contraception. And I urge you to go on the website and look at that, because it's very inclusive, and it's the latest up-to-date information on that without having to read all 100 package inserts at one time. It's excellent.
Right. Well, thank you for that. And we do our best to try to stay up to date. And I think that's you know, the whole fertility question is one that, because this disease generally occurs in older people, we don't always think about or ask. So it's good to ask, and it's very good to stay up on top of all those things. So, okay. Next question. They are just rolling right in here, Dr. McBurney. Am I prone to cutaneous lymphoma if I have other cancers? Probably a hard question to answer generally, but
Well, that is a hard question to answer, because I don't know the exact answer to it. As I said earlier, I think if there is something in your genetic makeup or something that makes you more prone to cancer, that theoretically, hypothetically, you would think you'd be more prone to it. But we don't see, for instance, an overwhelming number of cutaneous lymphoma patients that have had breast cancer or that have had colon cancer. Rather, the reverse is what we generally tell people to be aware of if they have the cutaneous T-cell lymphoma, to look out for other cancers. As a general rule, as a general answer to that, though, is I don't think if you've had one kind of cancer, you need to be worrying or have a high anxiety level about developing cutaneous T-cell lymphoma.
Right. Right. And again, it probably goes back to looking at your family history, looking at your lifestyle. You know, if you're very fair skinned like me and you spend a lot of time out in the sun, I probably have a higher risk of skin cancers and melanoma, no matter whether or not I have cutaneous lymphoma. So, you know, again, it's getting your screenings, look at your family history, and making sure you're staying on top of things, and then don't worry too much, because anxiety can be worse than the disease itself, right? Okay, let's see. I entered this before the program started, just in case I did it wrong. Well, we're glad you're here. The question is, when is the use of low-dose Campath indicated in Sezary syndrome? Good question.
Well, Campath is a very intense intravenous chemotherapy that not only suppresses the T cells, but also the B cells. And because of that, it is very, very effective in treating Sezary syndrome, but it has the side effect of causing generalized immunosuppression. And now we've got some other newer drugs and newer techniques that I often will hold the Campath in reserve and use some of the other methods first before I would go to the low dose Campath. Now, I would suggest that you have a complete in-depth discussion with your physician about this and ask for the other alternatives. And it may be, depending on your circumstances, that this would be a very good therapy for you. But generally, I don't use that very frequently.
Right, right, great. Yeah, and I think it's always good to have those kinds of discussions. And as you said, you know, we've got some new treatments that have recently become available. And I think the general rule of thumb is, you know, what kind of treatments would have the least side effects for an individual and have the best chance of managing the disease and keeping it under control. So we're fortunate these days to have some new options in our toolbox, and there's also some clinical trials going on that are hopefully going to bring to bear for everyone some additional therapies, both for early stage as well as for more advanced and more challenging disease. So, you know, I think there's a lot of hope out there, and there's a lot of options to be considered for folks. And I'll remind everybody that this is an open Q&A. So tonight with Dr. McBurney. So write in your questions, and we're doing our best to answer everything in the time that we have. So our next question is, my disease and current diagnosis of mycosis fungoides started from supposed tinea versicolor. If I was treated for this correctly, would it have progressed into CTCL MF? Ooh, that's a good question.
That is a good question. It's a challenging question. First of all, tinea versicolor, for those of you who are not familiar with that disease, is a superficial fungal infection of the skin. It is very, very common in humid climates, such as Louisiana. We see a lot of it. It also is mildly contagious, and it tends to be very difficult to completely eradicate. And clinically, it can look very much like early stage mycosis fungoides in that it can present with hypopigment, that is, areas of decreased pigment, or red scaling areas. There is no association that I am aware of between tinea versicolor and it causing mycosis fungoides. You could have had two diseases, or you could have had one disease that was not correctly diagnosed. But to say that tinea versicolor evolved into or caused the mycosis fungoides is not accurate. There would be no scientific basis for saying that. Can you have both diseases? Sure, you can, and that's very possible. But one does not cause the other one. The only way that I could think that mycosis fungoides could cause tinea versicolor is if you were being treated with drugs that cause severe immunosuppression, and you got tinea versicolor secondarily from the immunosuppression. But otherwise, I don't know of any other association.
Right. Yeah, I don't recall ever hearing that either. And I think that's obviously one of the big challenges with diagnosing early stage mycosis fungoides, is because it does mimic so many other diseases. It looks like so many other more common diseases. And even if you do a biopsy, sometimes it's still hard to make a definitive diagnosis. So it's I think that's a big question everybody always has. Well, gosh, if I had been diagnosed, did I have this earlier and I was just misdiagnosed, or did I have two different diseases, and does that really make a difference? You know, and maybe you can comment a little bit about, if you've got early stage mycosis fungoides that's just been diagnosed, but maybe you've had patches, scaly skin, things that may have been diagnosed as eczema or atopic dermatitis or, the other myriad of more common skin diseases. Does it have an impact, do you think, on the progression or prognosis of the mycosis fungoides? I mean, should
let me discuss that a little bit further. First of all, it generally takes about 6 to 7 biopsies before the disease is diagnosed. And that can occur sometimes over as long as 14 years. So that it's not a matter of somebody missing the diagnosis. It's more that the disease has not progressed to a point that we can diagnose it under the microscope. And that is why it is so important, if in people that I suspect have the disease, I suggest that they return every 6 to 12 months and we repeat the biopsies. And we do, and particularly if the disease changes. Now, the other question that comes up, and I'm asked this very frequently, is, well, what about if if they treat me with steroids for my eczema? Did they make my mycosis fungoides worse? And I always say, no, not at all. And the reason why is because steroids is one of the topical skin-directed therapies for mycosis fungoides. So I always emphasize to my patients that it's very, very important that even though they've been treated with steroids, it does not mean that it's made their disease worse. If anything, it's probably helped the disease. That's one of the first treatments recommended by the NCCN guidelines.
Right. And hence, it sort of answers the question as to why do I always have to get more biopsies? But that's just, kind of the nature of this disease, especially mycosis fungoides, is that it's tricky and it likes to evade our very, very good clinical diagnoses eyes. And so sadly, biopsies are kind of part of the whole thing.
And the other thing too is to remember that a biopsy, most biopsies are the size of a pencil eraser, if not smaller. And you're taking a pencil eraser size of your skin, and we're trying to diagnose a disease that is often involving up to 10 to 20% of your body's surface. And we may not get the perfect place. And that's the other reason that multiple biopsies are necessary. The other thing too is that when we're doing these biopsies, that all topical medicines, particularly the steroids, should be discontinued for 2 to 3 weeks before we take those biopsies. And so if you're going to a physician to see if you've got this disease, I recommend that the medicines be discontinued for 2 weeks before going, because the steroids can suppress the picture under the microscope and we will miss the diagnosis.
Right. Yeah, that's a very good point. And I think that's something we all need to be aware of. And again, why multiple biopsies are sometimes necessary and required, either multiple spots on your body at the same time or multiple biopsies over the course of time, maybe from multiple spots if you have spots around your body, and stopping treatment so you can get the best chance at getting a good sample to do a good diagnosis. So it's tricky. It's a tricky thing. So that's always good to know. All right, let's see. Let's see. Oh, this is about low-dose Campath. Can you give it subcutaneously? Or how is that, how is it delivered?
It can be, and the answer to that is yes, it can be. It depends upon the oncologist delivering it.
I see. That's good to know. That's good to know. All right. So I'll say again, everybody, this is an open Q&A program with Dr. Elizabeth McBurney from Metairie, or well, actually outside of the New Orleans area in Louisiana. And oh, here we go. See, I always know if I give people a second, they're typing rapidly while we're chatting. My husband's diagnosis was recently changed from MF CTCL to PTCL, so peripheral T-cell lymphoma, not otherwise specified. It's limited to the skin. He's on CHO-OP and stem cell transplantation has been recommended. Are there other treatment options short of a stem cell transplant? Boy, that's a tricky question. They're throwing some good ones at you tonight, Dr. McBurney.
Well, this is a tough one, and the short answer is there are other options available, but it's very hard to pick just one to suggest. I think this is the case where it's very important to sit down with your oncologist and your dermatologist and look at all the options that are available and what best would suit you as a patient, and to know the risk and the benefits of each one. A lot of it depends on the age of the patient, of the other illnesses of the patient, such as if they have chronic obstructive pulmonary disease, or they have heart disease, if they're very old and not very mobile. There are a number of factors that come to play here. So it's not easy to say that there's nothing else to do. The other thing I always encourage my patients to do, if we've got in a more difficult situation, like it sounds like this patient has, peripheral T-cell lymphoma is rare. It is not near as common as mycosis fungoides. And I often recommend a second opinion. I think that sometimes that has two functions. Number one, it gets another set of eyes looking at the patient and another set of ideas, or it may only validate what you're doing anyway. But both of those things are excellent for the patient to be able to make a decision about a difficult disease that we do not have enough cases to say the best treatment for this disease is X or Y. Like we know for strep throat, we treat it with penicillin and it's gone. We don't have that with peripheral T-cell lymphoma at all. And it's considered one of the aggressive forms of cutaneous lymphoma. And there are other options, but as I said, you need to sit down and discuss the risk and the benefits of them and individualize them for the patient.
Yeah, and I think that's always the case. These group of diseases are rare, and when you get the rarer of the rare and the rare, it's good to really have those kinds of conversations. And I think second opinions I think that's a really great recommendation. Again, because most all of the experts in the field of these kinds of very rare lymphomas are all connected. You all talk to each other, and just getting that a second set of eyes, as you said, can sometimes either raise something that wasn't seen before, or an idea or another option, or validate what the options are, and then that makes it a little bit easier, although never easy, to make the right treatment decision for that individual person. And ultimately, we as patients we have to make the best decision for us based on all the options available. So we have a listing of the treatment centers on our website, so you can go out and look at the different centers, and contact information is there if you're interested in getting a second opinion. And you can always call us, and we'll help you figure out who's closest to you and how to get to some of those folks if you're interested. So good luck with all of that, and happy to help in any way we can. Okay, next question. I was diagnosed with primary cutaneous marginal zone. I'm starting again. I was diagnosed with primary cutaneous marginal zone B-cell lymphoma. Is anyone doing research? Gosh, the questions are really good.
Good. First of all, primary cutaneous marginal B-cell lymphoma is one of those diseases that has an excellent prognosis. It is very responsive to therapy, and very often patients will live a long life, and their cause of death will be from something else. So that the prognosis is excellent. Susan may be better able to answer this than I am. I'm not aware of anyone who is limiting their research to primary cutaneous marginal B-cell lymphoma. There are certainly, in many of our large centers, there are people who are studying B-cell lymphomas, but I must admit that most of our studies have been directed to the more aggressive forms of the disease, of the aggressive forms of B-cell lymphomas, rather than the marginal type. The marginal type actually for many years was almost treated like a pseudo lymphoma, not a real lymphoma. It is a real lymphoma. It is a valid lymphoma. It's a valid cancer, but it has a very, very good prognosis, as opposed to some other types of B-cell lymphomas that are primary cutaneous to the skin, like the type that occur on the lower legs of older women. There's a very more aggressive form of the B-cell lymphoma. Susan, are you aware of anybody who's doing research just on that form? I know there are studies that are studying lymphomas.
Yeah, I'm not aware of anybody doing research specifically into the more treatable cutaneous B-cell lymphomas. And I think the reason, as you pointed out, is that we have good treatment paths and plans for those cutaneous B-cell lymphomas. We're able to treat them, and the responses are usually pretty good. And people live, as you said, a long time with these primary cutaneous B-cell lymphomas. So most of the research is being done in the areas that we don't know a lot about, and we can't quite figure out, and we don't have good treatment paths to resolve them. But to your point, I think that a lot of the research, it doesn't necessarily exclude those, but we have a better approach to treatment that has good results. And so, most of the research is going into those areas where we don't have a lot of answers, and we're trying to figure it out. But hopefully the person can get treated and be on their way and live a long and prosperous life. Okay, let's see. Forgive me if you've already spoken on this topic, but is CTCL a disease that gradually progresses, or can the disease go back and forth between stages? Oh, that's a very good question.
Well, interestingly, in this case, it depends. For instance, most patients that start out with stage 1A disease almost about 87% of them stay in that stage. It's an early stage. Less than 10% of the body surface is involved, and they never progress. However, that does mean that about 13% do. In stage one, in more advanced stage, or stage 1B, you can get as up to 60 to 70% do not progress, but that means between 30 and 40% can progress. Now, once you get treated, it is not unusual to go into remission. I do not ever use the word cure with my patients. I talk about long-term remission. And so, for instance, if you had widespread disease, greater than 10% of your body surface, and you received a therapy that completely cleared you, you may go a long period of time before you begin to have disease again. So in that sense, it is possible to go from having a lot of disease to very little or no disease, to then going back to having more disease or a lot of disease. It depends on a number of factors. First of all, your stage of your disease when you're diagnosed. And the second thing is the kind of treatment that you're receiving, and if it's cleared you up and put you into a remission. I don't use the word cure with my patients because I think it's highly, highly unlikely. And I generally just like to talk about long-term remissions. I must admit, though, that there are some people in the field who will talk about people being cured if they've gone 8 to 12 years and not had any reoccurrence of their disease. I generally do not use that term. I just say they're in long-term remission. But to directly answer your question, it is possible to go back and forth into various stages of the disease.
But in general, and I could be wrong in this, so please correct me, but I was under the impression that if you are, so for example, I was diagnosed with stage 1A, you know, because I just had a little bit of rash around my waist, but then my disease progressed to tumor stage and then back again, you know, so I've been kind of back and forth, but technically I was diagnosed at stage 1A, so I theoretically stay on paper at that stage, even though I've been back and forth and all over the map ever since. And maybe I'm not right in that description.
Well, we've kind of evolved on that. We used to say whatever you were diagnosed originally, that was your stage all the way along. And the problem is that it doesn't adequately explain to the patient where they are now. And so what I will usually do in our notes is we'll say initial diagnostic stage was stage 1A, less than 10%. But then I will put the tumor burden today is, and whatever it may be. And that is how I will list it on our charts. And I will restage them based on what they have today. But always they will begin as initially being diagnosed as a stage 1A. And that is important that you differentiate between those two. When you're doing drug studies, that becomes very, very important, that you accurately diagnose the amount of tumor burden they have at the initiation of the study.
Got it. Got it. That's very helpful. See, I always learn something. It's amazing, no matter what. Okay, let's see. I've been prescribed the steroid clobetasol for my patches. I'm starting to see the area around the patches start to turn a lighter pigment. Should I stop using the clobetasol?
Well, you have been very observant, and that is correct. The clobetasol, one of the side effects, it's a what's called a class 1 steroid, and it can cause loss of pigment. around the treated areas. And when I see that in my patients, what we do is sometimes modify the treatment. Do not stop treatment. But by modifying it, I mean, I sometimes will combine clobetasol once a day and put a retinoid on at the opposite time of the day. Or I will, if my lesions have responded to the clobetasol and are much thinner, I will then go from a class 1 steroid to a mid-potency topical steroid like triamcinolone. The other thing is, if you are getting a lot of side effects from the clobetasol, you can change to an entirely different type of skin-directed therapy, such as topical nitrogen mustard, which is sold as Valchlor, or imiquimod, or topical bexarotene. These are all options that can be used, but I would not stop the medicine without consultation with the doctor who prescribed it and discuss this with them and the other options that are available.
Very good point. So we have, wow, we're almost out of time. Can you believe it? So here's our last question, Dr. McBurney, for the night. I hear a lot of people with cancer talking about the food we eat, mainly the sugars, and seem cutting out sugar helps in recovery. What do you think? And has anyone discovered any links, I guess, between food or sugar and cutaneous lymphomas? Oh, a good question to end on.
That's a very good question to end on, because it just shows us how much more research we need to do. I do tell my patients this, and they frequently ask me this question. First of all, I think it's very important when you have this disease that you stay in good health, that you keep yourself in good physical shape, to exercise, to lose excess weight if you have it, and to move, and to eat well-balanced diet, and not just all hamburgers and pizzas. However, there has been no study that has shown that a low glycemic or low sugar diet is going to affect your mycosis fungoides. The other question that is asked frequently is, what about a gluten-free diet? Because we know gluten causes inflammation in the skin. And once again, there's no firm data on that. But I personally think a low gluten, low sugar diet is a good diet generally to have, because it will help maintain your normal body weight. And remember, these are our patients with this disease are generally older patients, and they have more difficulty in keeping weight off, and they more easily gain weight. And so I see no harm in doing it, but I don't see any therapeutic advantage to your disease to do it. And I hope I've answered that question.
Eat healthy, exercise, and, you know, everything in moderation, right?
Everything in moderation, except, yes.
Because I will say I like a good burger, and I have a tendency to enjoy my pasta, which, you know, gluten-free is a little hard, but I do my best. But
that's more difficult than the sugar-free. I agree, it is, but it's possible. You can moderate.
That's right. That's right. Well, Dr. McBurney, we've come to the end of our time together tonight, and I really want to thank you for joining us and sharing your wonderful wisdom and expertise and insights. And it's just such a delight to have you on our program. And I know we have to come back down to Louisiana. I love coming down to your neck of the woods